So this is about eCLIPs. Most of you will know eCLIPs, but the thing is almost nobody uses it. So, but anyhow, I still think it's interesting to share the results with you. And so what I did is, or what we did basically with some other eCLIPs users, we selected cases that were used with a very unfavorable anatomy, so extremely low dome to neck ratio, with this, and aspect ratio, so that have a high recurrence risk. So 12 centers, only 24 cases, so that's not a lot, but let's see what we have. So we have different options for wide neck bifurcation aneurysm, but I think all of us, we struggle with that. Sometimes it works, but there are a lot of recurrences. We see that in the literature, even in the recent literature. Also, we like web. We use it a lot, especially ruptured cases like this old lady. It's not a good case. I think you can coil it, but it's a wide neck. It has a high recurrency rate. And it's not a good case for clipping otherwise. So here we put a web. And of course, we learn also. We do everything with the... talk a lot with the company, with the sales reps, to oversize this a little bit, especially the width. So that's what you basically see here as well in the image. And it looks nice after 6 months, but then after 1 year, and that's what we see more and more now, that we see the late recurrences. And sometimes I wonder, I think we are the only center that has that, because everybody loves it, and we like the web as well, but we see a lot of recurrences, like almost half of the cases you see here. The aneurysm is back 1 year later, and it is a ruptured aneurysm. So, and we know also from literature that ruptured aneurysms, when there's a remnant, they have a higher risk of re-ruptured. Different story compared to unruptured aneurysms. But this is a problem. So maybe there are other devices. I don't know. So this is the eCLIPs. All of you probably know the device. It's not like a circumferential stent. It has a little bit high. It's a little bit more metal coverage, like 30%, compared to a flow diverter. It is non-circumferential, and you do it together with coils. So you have an intersaccular flow diversion and intravascular flow diversion. So you take the both worlds for that. So again, to emphasize, this is not the same as a stent or a pulse rider or a peak honus, which have a more than 90% open area. I was thinking it's amazing that you pay for something that is 90% nothing, and you pay a lot of money for that. So we want to be sure that it's really true, that flow diversion effect. So this was studied in London in the CFD, and you see it's almost the same. There are 5 aneurysm models. It's by means of shear stress. It is the same reduction compared to a braided flow diverter. It's a little bit less in inflow reduction, but basically it's not a huge difference. So that helps a little bit. The thing is, and that's probably also why many people maybe don't like to use it. It's a bulky system, triaxial system. It's a long sheet, and you need a Nevians, and you need a Fargo over this wire. But I basically think, well, let's see here, that basically think that it might be a nice challenge to do this procedure, because otherwise most of the neuro interventions, let's see if I can find most of the neuro interventions are so easy now that it becomes maybe even boring. And so maybe now a little bit more difficult procedure is maybe nice. It's funny. So otherwise it becomes so boring. Just putting a web in 5 minutes, and then you drink coffee whole day. So now it keeps your CBF also a little bit high, so which is good for your brain.
You are the driver.
That was sorry, of course. So here, this is was coiled in another center many years ago, like a large, it's not yet giant, but a large basilar tip, partially thrombosed, Recurrence is the progressive neurological deficit. So this is not nice. This are horrible cases, and maybe even hopeless cases. What can you do? Bypasses. We've seen it all. This is everything you do is you're not sure about the results. So we said this might be an interesting case, a good case for eCLIPs, and so that's what we did. Put the eCLIPs and put coils. Looks good. It was, of course, how can you exactly remodel the basilar tip? You never know what is completely normal anatomy. So this is the 2-year follow-up. And she was progressively deteriorating before the procedure, and now 2 years long she is stable. And if you compare the images between 17 and 19, I think it looks pretty okay. The aneurysm is not growing anymore, and it's like a Raymond 2 remnant, which is stable until last year. So some case illustrations, this is about the results. 24 patients with dome neck ratio lower than 1.6 and aspect lower than 1.3. It was chosen based on the literature that we know that was unfavorable. 12 centers. So we wanted to have independent reviewers to have to make the results a little bit more believable. So that was qualified people in the centers. And we had an independent neuroradiologist, experienced neuroradiologist. One case went really wrong. I was there. That was in the UK. It was a wire perforation. We missed that during the procedure. It was extremely stupid, of course. It was a very distal. It was a carotid terminus. It was a very distal wire perforation in the A3 segment, and we saw it later on when was a rather young lady with multiple aneurysms. And also in the ICU, I think maybe they didn't put really good attention to her, but so she passed away. The other patients went well, so it's more like all or nothing. So this is again a lady with a recurrent basilar tip, large aneurysm, and she had some Parkinson's symptoms, hemi-Parkinson symptoms, probably because of this cyst. Again, eCLIPs and coiling, and then at 6 months follow-up looks stable, and she improved clinically, although radiologically it's the same. The cyst is not smaller, but clinically her Parkinson's symptoms decreased, so she's very happy with the result. Again, here a lady with recurrent basilar tip. As you can see, this device is only because of the larger catheters you can only use for a basilar tip and a carotid, not for ACOM or MCA or other stuff. Again, here, same stuff, and this is after 15 months. What you see here, that's why I want to show you that if you look at the lateral right upper image, that you can really nicely see how the coils conform to the implant. So this is radiological results by the Coil Lab. The end of procedure, so we tried, we have had lessons learned for the earlier years that it's wise to have as much coils as possible. So that's why you have 60% Raymond 1 end of procedure. We see it follow-up, and that the mean follow-up is about 2 years. No, it's about 3 years. You see, you get a progressive occlusion. It's not dramatically, but it's a little bit better. So that probably speaks also for your flow diversion effect. So basically, you end up with one patient only, in this case series, that has an incomplete neck coverage, and all the other ones you would call, nowadays, in the new era, we call that satisfactory occlusion. In this case, with incomplete neck coverage is a case here in Spain, was a ruptured carotid terminus aneurysm that was coiled and regrew. And it was impossible to get access in the A1, so that just didn't work. And so what we said, okay, we just can do it like T stenting, but then only one part of the T. Just drop the, don't try second branch access, just drop the implant exactly at the medial part of the neck. So I can't find my, anyhow. So, but that didn't work. And I also think the coiling was not very dense, so that got a clear recurrence. So that's the only one. So from this series, you could say basically it's a safe and controllable delivery with a high procedural success and a progressive aneurysm occlusion. So we have the ESIS trial, the multicenter study, GCP study. We'll do next month the last inclusion, so it will take over a year, 1 year to have the clinical results. But there's also a new generation of eCLIPs, I will show you. So there are clear, why is there a new generation? Because there are clear limitations. We get a lot of feedback. I hear that the system is too complex. You need a smaller system. So it's a system with a free moving wire. So that was taken away. And there was a mechanical detachment that's now an electrolytic detachment. So the delivery system has now been changed. It's still one size. I think it's a major drawback because it's not, of course, one size fits all. But there's still one size. And the second bench access is a thing, as you can see here. So the left P1 is difficult to access, of course, with a large bore catheter. So this is the new generation in a model. And so it's like all the other stents now. It's in an O27 catheter. So you go with your O27 in here in the right P1, and then bring up here with the wire, then bring up your mounted eCLIPs. And this is a 14 wire. This is a 14 wire that is shapeable and torqueable. So you can torque that. You can adjust the shape, of course, according to the patient's anatomy. And so I can show that this is a first clinical case in Canada under compassionate use. Of course, it's not yet CE marked in any continent. So this is a case. Let's see. You see the aneurysm? So first it's in the right one. And then you unsheath it. Two videos now. Maybe it's interesting to watch this one now here. Try to stop it. This one.
This is device possible to rotate.
Sorry?
Possible rotate device.
That's what I say. It's a shapeable and torqueable catheter. It's like it's almost the same as an Asahi wire, the same configuration. So it can be four. Yeah.
This patient is with general anesthesia.
Yeah.
Look, it's moved.
I agree. I don't know what kind of anesthesiologists are here. You see here this image now he is torquing. And he's looking for the optimum.
I think it's recording from the screen, Luis. That's the video camera guy moving.
No. You saw also the roadmap is also moving.
The pictures move, but not the patient.
But I saw. I think what you mean. I saw the roadmap was moving as well. A little bit, yeah. Now it's moving a little bit. Yes, I see. Oh. Let's continue. Yeah, I can't find the mouse here.
Was he trying to cross there? Just?
He's trying to get access in this one, huh? Here. And he's torquing now. He's torquing now to get it to get access in the left P1. Then he's torquing a little bit more. He will then have the first into the cerebellar. Now jumps into the cerebellar. Then he pulls back a little bit, and then he goes upward. Okay, so then he is in the P1.
Is it?
Yes. Here you can see the run, and you see also some stasis. Then it's coiled afterwards, and typically because of the high mesh density of the implant, there's typically good coil retention. So try to coil as much as possible. And then you end up with this final result.
So it remains a single device. What he was trying to do is to push the leaflet on the left P1.
Yeah.
That's what he was.
It's mounted on the 14 wire, and so you can shape outside the patient according to anatomy. You can shape the wire, and then just push the wire into the second branch, and with that also the proximal end of the device. Exactly. Yeah. So this is a nice new device, and but all the devices in the beginning it's nice. In the beginning it's nice, but afterwards the devices, like Jaco said, will disappear and other things will be there. So don't worry about that. Okay, questions?